Good afternoon, everyone. Today I am going to present my study on suprailiac versus transiliac approach in transforaminal endoscopic discectomy at L5S1, a new surgical classification of L5 iliac crest relationship and guidelines for the approach. Percutaneous endoscopic lumbar discectomy for lumbar disc herniations has been an established and well-known procedure. Spinal surgery at junction areas has always been challenging. L5S1 level has its challenges for the transforaminal endoscopic procedure due to high iliac crest, sacral LR, large transverse process, wide facet joint, and narrow foramen. Transiliac approach at L5S1 allows entering into the disc in the line of inclination, but at the cost of drilling the ilium bone. On the other hand, suprailiac approach avoids these problems, but entry into the disc may not be in the line of inclination. This study aims to validate a new radiograph-based surgical classification guideline approach. This was a prospective study performed on a cohort of 90 consecutive patients of transforaminal endoscopic discectomy at L5S1 level. The pre-operative radiological assessment was done on anteroposterior and lateral radiographs of the lumbosacral spine. Note was made in radiographs to include both the hip joints in AP and lateral views and L5 spinous process equidistant from both the pedicles on AP view. All type of L5S1 herniations and all type of herniations at last mobile segment were included in this study. The cases with sequestered dorsally migrated herniations, concomitant multilevel bilateral lumbar canal stenosis, fixed pelvic obliquity, previous ilium deformity, and associated instability were excluded. This schematic AP view diagram of various radiographic parameters which were used in our study. The point IA is the most meter highest point on iliac crest in AP view. The point D is the midpoint of the posterior margin of inferior end of L5, and the point P is the point marked at 6 o'clock position of the ipsilateral pedicle. Line IAD is the line joining the point IA and D. This is the classification which was done on the AP view. It has been divided into three types. Type 1, point P lies above line IAD. In type 2, point P lies on the line IAD, and in type 3, the point P lies below the line IAD. This is a schematic lateral view showing various radiographic parameters which was used in the classification system. Point IAP is the most dorsal highest point of iliac crest on lateral view. EL line is the line along the superior end plate of L5, and the line PL is the line along the inferior margin of L5 pedicle. This is a classification which was done on the lateral view. It has been divided into three types. Type 1, the point IB lies below line PL. In type 2, the point IB lies in between the two lines. And in type 3, the point IB lies above the line EL. On the basis of the classification, following recommendations were made. If it is a type 1 with type 1 or type 1 with type 2 relationship, then you can go ahead with the suprailiac approach. If it is a type 3 relationship in either AP or lateral view, then transiliac approach should be considered. These are the surgical steps of transiliac approach. We start with standard AP and lateral radiographs. Various line drawings were made. Entry point is decided as per the type of location of herniation. It could be 45-45 posterolateral, tip of spinous process, or from dorsum facet joint. Then we go ahead with the needle placement, Tom Sherry needle placement, and then sequential reamers are passed on guide wires to make the transiliac window to the ilium and the foramen. For the clinical outcome analysis, the pre and post-operative mean VAS and ODI scores were calculated, and a paired t-test was used to calculate any statistically significant difference, any association between the type of approach and outcomes were also assessed. Total 90 patients were included in our study. 46 patients operated through suprailiac approach and 44 were operated through transiliac approach. This is a table showing the pre and post-operative mean VAS and ODI scores in both the groups. This is a case of a 48-year female who presented to us with left S1 radicular pain, MRI showing a large extruded disc at L5S1 level. The preoperative X-rays showing a type 3 relationship in both AP and lateral radiographs. Intraoperative radiographs showing the sequential reamers passing through the ilium and foramen, and post-operative MRI showing complete decompression of S1 nerve root. So to conclude, transforaminal endoscopy is safe and effective in almost all types of herniations at L5S1. Surgical classification based on X-ray parameters provides precise guidance for approaching transforaminal endoscopic discectomy at L5S1. Planning the surgery well before execution is the key. Suprailiac approach should be considered in type 1-1, type 1-2, and type 2-1 cases. In type 3 cases, transiliac approach should be considered. In type 2-2 cases, either transiliac or suprailiac approach can be considered. Surgeons uncomfortable with transiliac approach can resort to interlaminar approach or suprailiac approach with transforaminotomy and anelotomy. Our classification guidelines has already been published in Journal of Spine Surgery in 2019 as an original study. Thank you.